Hey, good morning, everyone. Let me know if you can hear me. All right, perfect. We'll get started here in just a minute. Hope everyone had a good weekend, and everyone saw the updated PowerPoint, everything last night. Got that downloaded. We'll finish up the antibiotic section today, and then move on into I think derm is next. All right, so let me get started here. All right, well, thank you all for joining me as usual. Looks like I got about 14 of you, so maybe a little bit of a slow morning. I can understand, but that's all right. I did have a question up here so far on the sticky board. It's a good one, I think. It says, when you mentioned the macrolides bind to the CYP3A4 enzyme, I thought of Eliquis. Does that mean that Eliquis is taken at the same time as erythromycin, CYP3A4 be inhibited by erythromycin, and therefore lead to increased levels of Eliquis, resulting in increased toxic risk of bleeding? That's absolutely what could happen. Especially depending on the agent, not everything that inhibits 3, 4 is, like 100% inhibition. There are strong inhibitors, there are weak inhibitors. So you all have to kind of take it with a grain of salt. And so if I had a patient who was on Eliquis, I would be much more hesitant to put them on something like erythromycin because of that risk of inhibiting 3A4. You're increasing levels of the Eliquis, and that does increase the risk for bleeding, right? And of course, all of the toxic effects there are certainly just an extension of the therapeutic effects of the drug. So certainly they wouldn't have a lot, most likely, but the bleeding risk would probably be too elevated. So if you could use something as an alternative, that would be beneficial. So we're going to run into a lot of other 3A4 inhibitors up here in the future. So that is absolutely true. Certainly something to keep in mind. Sometimes you're going to find these sort of CYP interactions will be like an absolute contraindication. This would be something I'd consider to be like a relative one. Maybe if you had to use erythromycin, there really wasn't another option, which clinically there generally would be. It'd be one of those things where I'd monitor for it, right? So you can say, okay, well, if you notice any bruising or bleeding, anything like that, certainly stop taking the medication, come in, we'll get you checked out, right? Because not all bleeding you can necessarily see. You have to check like CBC, check their hemoglobin, hematocrit, see where that's going, whatnot. So there's that. I'm going to start with the fluoroquinolones here. I think that's where I left off last time. So if anyone can confirm, that would be appreciated. Let's see. I remember going over daptomycin and linase last time. So, we talked a lot about protein synthesis inhibitors. We've talked about drugs that worked on the cell wall. Now I want to kind of switch gears a little bit and talk about some stuff that can actually affect the DNA of the bacteria itself. And so the fluoroquinolones are sort of the first stop here. Here you can see we have levofloxacin, ciprofloxacin, and moxifloxacin. Obviously, if it has a floxacin at the end of the name, then you can pretty well tell it's a fluoroquinolone. So pretty easy naming convention with that. There are other fluoroquinolones that are out there that you'll see maybe more often in like for ophthalmic use, for otic use. We'll talk about those as they become relevant. I'm mainly going to focus on the 3 that I mentioned on that last slide because those are the main ones we're going to see being used systemically for the purposes of treating bacterial infections. So the mechanism here. So this works on an enzyme called topoisomerase, otherwise known as DNA gyrase. And so this is an interesting enzyme, and we'll see this come up again when we talk about cancer drugs because we actually have some that do the same thing for human cells. But basically, topoisomerase is responsible for affecting the DNA. Now, normally when you have DNA that's not being actively read or transcribed, it's in a very super tight helical state. And in order for things like DNA polymerase to come and interact with the DNA, you have to unwind it. And so that's what DNA gyrase does and topoisomerase does. Basically, it induces these little single strand breaks in the DNA, and that allows it to sort of unwind, and then it will reseal that break there. And so it allows it to be kind of loose enough for things like DNA polymerase to come in and actually bind to it and do what it needs to do. So what the fluoroquinolones will do, they'll actually inhibit this process. They'll actually go in and prevent topoisomerase from doing its thing. And what that leads to is additional strand breaks. DNA can't unwind, it can't rewind itself. And so because of that, it causes eventual damage in the DNA, especially to the point where the DNA is so damaged, the cell just says, okay, let's just trigger apoptosis, and it, kind of suicides itself, right? So fluoroquinolones are useful drugs, but they need to be used sort of judiciously because of a lot of resistance issues and a lot of toxicity issues you're going to see here. So some people think fluoroquinolones are great, you can just use it for everyone, but it's sort of a double-edged sword you're going to see there. So with the fluoroquinolones here, you can see, use it for a lot of different things. I'll show you the stoplight metaphor here in just a minute, but I want to talk about just in general some of the things you're going to see with the fluoroquinolones here. Used for a lot of different disease states, especially like respiratory tract diseases, UTIs in many cases. We'll talk about why you don't want to use moxifloxacin for UTIs in just a moment here. Skin soft tissue infections, it treats a lot of things, and you can probably think of its spectrum of coverage sort of similar to things like the macrolides or maybe the tetracyclines, sort of similar to that. We'll see there's some additional benefits to it here in a moment. However, a lot of issues. So, for instance, it will share some of the issues we've seen with things like the tetracyclines and things like the macrolides. So, for instance, if you were to take a fluoroquinolone with an iron-containing multivitamin, or if you were to drink it with milk or something like that, it will then chelate with those ions. So, iron, antacids that contain calcium, things like that will prevent the fluoroquinolone from being absorbed, and thus your drug's not going to work, right? You can also see QTC interval prolongation, like we saw with the macrolide. So that can put the patient at risk for things like torsades, due to that prolongation of the repolarization phase of the ventricles, right? CNS issues in the elderly patients. You can see worsening, things like dementia and things like that, and you're not sure, one of the things you'll find is when elderly patients get an infection, whether it be just even a simple UTI, it can really throw their mental status for a loop to where they're just not acting right. You're like, what's going on here? Is it dementia? What is it? You don't know if it's because they have an infection or is it because of the medications you're giving them too. So sometimes you will avoid fluoroquinolones in those elderly patients due to those issues with that, right? And then by disrupting gut flora, you can see some issues with warfarin. We've talked about this before, and generally things that tend to have more effects on the anaerobes that are just sitting there growing in the GI tract, the more likely are to see these warfarin interactions. Because if you recall, we get a lot of vitamin K absorption due to the metabolism effects of those bacteria. If you lose the bacteria, you get less vitamin K, and thus this can increase your propensity for bleeding here. So Savannah's asking, when a drug interacts with calcium and dairy, should the patient avoid dairy products entirely during treatment or just not take the drug with dairy? That's a very good question. Yeah, you don't want to tell someone to say, well, you can never have dairy again, right? Because that'd be pretty ridiculous, and many patients may not be compliant with that. Especially when you think about elderly patients and you worry about the risk for osteoporosis and things like that, like they need calcium, right? So the question is like, well, how do you kind of avoid those interactions there? And so typically, and this is the general rule of thumb, if you have two medications that are able to bind up to one another, typically what I would say is you could either take the fluoroquinolones, say like 30 minutes an hour prior to the iron-containing product or the dairy-containing product, or I would do it, say, 2 to 3 hours after, right? You want to separate them enough in the GI tract such that they have kind of a low chance of them sort of meeting up. Is that going to work all the time? Maybe not, but that's a general rule of thumb. So either 30 minutes to an hour before or 2 to 3 hours after. Especially when you think about things like milk that are kind of liquid and they kind of coat things as it goes down. That will give it enough time to sort of kind of move itself along before you take the fluoroquinolone. So that's why we give a little extra lag time on the after portion there. So there's that. Now, as I mentioned, fluoroquinolones get a lot of overuse, and so they get a lot of resistance. Most people going in with cough, runny nose, low-grade fever, it's viral, but they still want an antibiotic. Many people just give them a fluoroquinolone, and so that's not great, and that's led to a lot of resistance. Not only that, we're going to see there can be some collateral damage in terms of some of the side effects we see here. It means you can single out resistant bacteria. We'll see some other sort of unique side effects here in just a few moments, and you have an increased risk for C. difficile, right? That being the opportunistic anaerobic infection that can take hold as you disrupt the normal gut flora, right? So I'll start off with a second generation fluoroquinolones. Keep in mind though that there are a first generation, obviously, but we don't really use them from a systemic standpoint. I'm really only going to talk about the 3 here, but just know that there are others that will pop up later on. If you ever see a drug that ends with fluoxetine, it's a fluoroquinolone. You can be rest assured with that. First off, talking about Cipro. Cipro is very good because it has nice, gram-negative and atypical coverage here. We don't typically use it off the bat for like anaerobic infections, even though it can disrupt that gut flora pretty significantly. The other thing too here is that Cipro kind of has plus minus sort of coverage on Pseudomonas. So if I had a patient who I suspected to have Pseudomonas, say for instance they're coming in from like a nursing home or they've been hospitalized recently and were on broad spectrum antibiotics. My mouth has not woken up, obviously, as you can tell. This would not be the drug to go with, but we use it a lot for things like, maybe slightly more complicated UTIs. If I have a patient who's maybe developing pyelonephritis or something, this could be a really good option for them if you didn't suspect Pseudomonas playing a role here. Again, renal dosing for all of these fluoroquinolones, except for one exception, which I'll mention here in just a moment. So really got to watch this. This is a big one that I see a lot of patients or a lot of providers not checking renal function for, and so they can end up kind of overdoing it and leading to some of these toxicities here. Levaquin, though, very common one you're going to run into in the hospital setting here, even outpatient too. You can see it pretty often. This has additional gram-positive and pseudomonal coverage here, and so when you hear about things such as what we call a respiratory fluoroquinolone, which we'll mention more in the pulmonology section later, this is sort of what we're referring to as pretty good coverage in the respiratory tract. However, you are going to see that, resistance through strep pneumo is going to become a problem later on. So we'll definitely see that. But it has good atypical coverage, covers strep pneumo, so use it a lot for community-acquired pneumonias. Even in the hospital, we could use it to help kind of double cover for Pseudomonas too. So you may see someone who's on like Levaquin plus, piperacillin tazobactam, the Zosyn, or you may see cefepime plus Levaquin, and that's perfectly reasonable because if you're trying to double cover for Pseudomonas, then you need 2 different mechanisms. And so these would provide 2 complementary mechanisms in that sort of same way that something like gentamicin plus, a beta-lactam drug would do complementary mechanisms there. Again, renal dose adjustments, so you got to watch out for that. A lot of people like Levaquin because it's pretty easy dosing. You just do like 500 to 750 daily, and then you're done. You don't have to think about it. But remember, the renal function is really, really important there. Okay. And then we have moxifloxacin or Avelox. This one's the interesting one because, one, it doesn't have great pseudomonal coverage, so you probably won't use it for a lot of pneumonias right off the bat, unless it's more of like a community-acquired one where you weren't thinking about Pseudomonas. However, you do not want to use this for urinary tract infections. This is a big one here because the fact that it gets metabolized entirely in the liver, and so it really doesn't get into any significant concentrations in the urinary tract. So if it never makes it to the urinary tract, then it's never really going to be able to interact with those bacteria and kill them off. So you cannot use it for those type of infections, okay? Other than that, though, this is beneficial because you don't have to worry about renal dose adjustment because it doesn't undergo renal elimination. So that is one sort of benefit to Avelox that may counterbalance sort of the negative of not being able to use it for UTIs, because those are pretty common infections. So, as I mentioned with the fluoroquinolones, some additional side effects to think about include things like photosensitivity. So, especially being in Florida, you're going to run into this, or patients may have increased risk for things like sunburns. You can see some inhibition of CYP enzymes like 1A2. This is less clinically important than like a 3A4 inhibition, but when it comes up, it's important to be aware of it. So again, this is a situation where if you have a patient who has a medication history, a medication list, run it through an interaction checker and just double check that if you're adding something on, that's not going to, all of a sudden cause inhibition and lead to an issue there. But that can occur. Remember, watch out for that QT prolongation. Typically when it's by itself, this is not going to be such a big issue. So if I had like a healthy individual, like, typical, 30-year-old individual, no significant past medical history, UTI I'm treating, I'm not going to worry about QT prolongation in that type of patient, right? It's the more complicated ones that are on multiple medications taking QT prolonging drugs. If they are, if they have a congenital prolonged QT due to, heart defect or something like that, those are the things you're more worried about in causing prolonged QT. And again, you can monitor for this. You can check an EKG. at baseline, and then after they start taking it to kind of see where that QT is going, and if it's significantly prolonged, then you may consider stopping the drug entirely. This is another unique thing you'll see with the fluoroquinolones. Really won't see this anywhere else. This tendinitis and Achilles tendon rupture. This is something where you see this more often in children. So we say really anyone then less than 18 years of age, you want to be cautious. Doesn't mean we don't use it in kids. It just means that if we have other options that are available, like if I can use amoxicillin instead of Levaquin, I'm going to go with that every time. I don't know the full mechanism for why this happens. I don't think anyone has a good idea of why specifically this occurs, but we do know that it interacts with something in the tendons to lead to pain and can actually lead to rupture in some cases. And that Achilles tendon tends to be one that will occur more frequently. That's kind of what's reported most often there. So it's something to note. I mentioned the CNS toxicity. This is especially in elderly patients, and then even sometimes you can get some like peripheral neuropathies. And typically what you're going to see with a lot of medications is they tend to affect the really distal neurons most frequently. So oftentimes when I talk about peripheral neuropathies, they'll have what they call a glove and stocking distribution. So it means they're going to be affecting like the fingers and the hands and the toes and the feet more frequently than it would be something a little bit more proximal to the central trunk, right? So those are things you want to be watchful for. Now let's get into sort of a miscellaneous bunch of antibiotics here. First off, let's talk about clindamycin. This is also going to be a protein synthesis inhibitor, but its actions are so different from the other ones that we talked about that I like to sort of cordon this off and talk about it by itself. Clinda is a really good drug. However, there are going to be some caveats with its use since it is pretty specific. This is a really good gram-positive active drug. It has really good activity against MRSA, for instance. And again, my head's covering up the stoplight, but you can see that on your copy. Really good MRSA coverage, really good activity against gram-positive aerobes. It has like no gram-negative coverage though, right? So for gram-negative aerobes, this is not going to be a good drug. You would not use this for a UTI unless you specifically knew what the bug was. But it has also really good coverage against gram-positive and negative aerobes, okay? So that's kind of its unique sort of niche here, is it's got good anaerobic coverage, good gram-positive coverage, including MRSA, no gram-negatives, okay? So what do we use it for? A lot of like skin and soft tissue infections here, things like osteomyelitis. Sometimes if we can use this for intra-abdominal infections, but we'll use it in combination with something else that can cover sort of the gram negatives, right? So maybe you'd mix this with like something like a cephalosporin or something, for instance, right? But those are things you can see. Also note here, this is interesting. It can be used for toxin-mediated diseases. And what I mean by that is if you had someone who had something called toxic shock syndrome, that's a case where you have something like, gram-positive bugs, like, staph or something that releases exotoxins. It can lead to really profound sort of shocky looking pictures. And we'll learn about this in a later date. But you can actually use this because clindamycin will bind up those exotoxins. It can actually really help prevent some really significant morbidity and mortality in these patients here. So, the classic case I think of a toxic shock is like when a patient has left like a tampon in for too long, and all of a sudden that has sort of harbored this infection, and then they get really profoundly septic looking. A lot of it is related to those toxins being released from the bacteria. This is a good drug to add on to that. So something you may see occasionally. Now, with clindamycin, some of the problems with it you're going to see, and this is kind of the most, the biggest thing to worry about is going to be C. diff and the pseudomembranous colitis. This is probably the more common thing you're going to be thinking about with clindamycin, and that's because it has a propensity, because it's so good at killing all those anaerobes in the GI tract, is it can cause C. diff. It doesn't treat C. diff, but it is a causative thing, probably the most common one you're going to think of as causing C. diff. And that C. diff can then progress into something called pseudomembranous colitis, which is just this really intense inflammation of the colon, which we would like to avoid if at all possible. Remember, we've already talked about one thing that can treat C. diff. So, for instance, oral vancomycin is going to be a good option for that, not IV, but oral. We'll look at another one here in just a moment that can treat that as well. Next up, we have sulfamethoxazole and trimethoprim. These is a combination medication you're going to find together all the time, usually in a fixed combination. So if you've ever heard of like Septra or Bactrim, that's kind of what I'm referring to here. If you ever hear of like a single strength or double strength, that's how they're frequently termed when they come in tablets. So Bactrim DS or something, that just means Bactrim double strength, and it refers to the concentration of the drugs here contained in those tablets. So anyway, so how do they work? Well, this is interesting because it actually, again, works on the DNA, but this works on the actual formation of the DNA. And so it works through this process here where normally folic acid would be sort of introduced into this process here where it could be turned into what they call tetrahydrofolate. And tetrahydrofolate is really important for helping to produce new nucleotides for the DNA. Okay, if I can inhibit this process here, and you can see that sulfamethoxazole sort of works on this first step here of converting PABA into dihydrofolate, and then you're going to have trimethoprim inhibit this process of converting dihydrofolate into tetrahydrofolate. Point being is that you're going to have less nucleotides being made and less DNA being made. And if you can't make new DNA, that eventually leads to enough damage, again, where apoptosis is going to occur, right? So this would be considered like a bactericidal sort of medication, just like the fluoroquinolones could be, right? So anything directly damaging the DNA is considered to be cidal, right? So Bactrim has a wide range of uses here. A lot of people know of Bactrim as being used for like a lot of UTIs. Has pretty good gram-negative coverage. Does have good gram-positive coverage, including things like MRSA, but it doesn't cover enterococci. So that'd be one sort of hole there in its coverage. The thing I use it most frequently for in pediatrics is dealing with patients who are more immunocompromised. So, for instance, if you have patients who have like cystic fibrosis, who are sort of chronically immunocompromised to the point where they get some really kind of oddball bacteria, things like Burkholderia cepacia or Synatrophomonas multifilia. Or if I have someone who, for instance, has cancer and they've been treated with chemotherapy to where we have now suppressed their immune system through that. We worry about things like pneumocystis carinii, we worry about things like toxoplasmosis, nocardia. We can give that to them as well in order to prevent those infections from happening. So you may see this being used as more of a preventative, as a prophylactic antibiotic instead of actually treating a specific infection. But that all depends on where you're working at. If you work with adults most of the time, you'll probably be seeing it used for things like skin and soft tissue infections, UTIs, and that sort of thing there. As I mentioned, PJP pneumonia, pneumocystis jirovecii is kind of the newer nomenclature for that. We'll find some patients can be used both as prophylaxis and active treatment once they do develop that infection. Again, this is more of an issue for immunocompromised individuals, not normal, typical, healthy individuals. Use this a lot for like UTIs and prostatitis, some respiratory tract infections. Maybe if we had a patient who was like, I probably wouldn't use this empirically, but if I had someone who had a resistant H flu or strep pneumo or something like that. And then also if you have people who are maybe undergoing like some international travel or something, to really worry about like traveler's diarrhea, sometimes you'll see it used for that as well. So a lot of good uses for Bactrim. However, there are some downsides to it. Again, because it's inhibiting the bacterial DNA production, it can actually affect us as well to some degree. And so you do have some risk for things like thrombocytopenia and agranulocytosis. And again, this wouldn't be good in someone who has immunocompromisation, right? Because again, they're already maybe neutropenic to begin with. This would just worsen that. So certainly you may consider monitoring their CBC if they already have maybe pre-existing blood dyscrasias or something like that. Another interesting one here too. This is probably I know we mentioned it with the penicillins, but this is probably going to be a bigger risk for things like Bactrim is going to be the Stevens-Johnson syndrome and that toxic epidermal necrolysis. You really want to educate patients that while it's a very low risk to occur, if they start to notice, new onset rashes or blisters or anything like that, they need to call in and at least talk to a provider to see if they need to stop taking the medication or if they need to be referred back to the ER like immediately, especially if they're having like any kind of skin sloughing or blisters starting to form. I would definitely just say, hey, just stop taking it, go to the ER right away, right? Those are the big things you're going to see with that. There are a significant number of drug interactions which are notable here, and it has to do with things like CYP2C9 inhibition. This is a big one that you're going to see here. This is a big one with warfarin especially. You can actually see some pretty significant INR bumps because if you recall, warfarin, a significant amount of one of the enantiomers there underwent metabolism through CYP2C9. So I've had cases where patients would be on warfarin. They were at a stable INR of like 2 to 3 for AFib or something like that. And then, they saw a different provider. Maybe they went to like an urgent care or they went to like a minute clinic or something like that for an infection. They got prescribed Bactrim. And then all of a sudden they come back and their INR is like 9. They come in for bleeding, right? So you got to be really, really cautious there. We had to, give them vitamin K and FFP and all that good stuff. But It's not great, so you gotta be careful with that. It can also lead to inhibition of some other enzyme systems that aren't specifically CYP related. If you recall, there's a lot of enzyme systems that are out there, but CYP being kind of the most important one, but there are others as well. And so you can affect a lot of different medications here. So for instance, you may have things like, anti-epileptic drugs like phenytoin being affected, leading to higher levels. Digoxin, which is a heart medication we'll talk about later. I'm not going to ask you specifically on these drugs if we didn't actually like cover them, but like the warfarin one, you should know because we just went over, warfarin just, a couple weeks ago. So those are things you can run into. Not only that, but there's a drug called methotrexate, which is abbreviated as MTX, that can actually lead to some decreased clearance there. And we'll find that methotrexate kind of does the same thing to human DNA as Bacterium does to bacterial DNA, and so those can be pretty synergistic. So we'll talk more about that when we get into like rheumatologic conditions and cancer and things like that. So sit tight for that one. Up next, we have Flagyl or metronidazole. This one is interesting, and it interacts with some of the DNA to cause some helical structure loss and some increased strand breakage. Kind of similar to the activity of fluoroquinolones, but through a different sort of mechanism. It doesn't affect topoisomerase directly. This one more kind of directly causes strand breakage. This one is a very niche sort of use here, but where it's useful, it is kind of the go-to drug in a lot of senses. This has really good activity against all manners of anaerobes, but it does not cover any gram-negatives or gram-positives. It also covers parasites as well, so you're going to see this used for a lot of like vaginal infections, trichomoniasis, and things like that. Also, it's going to be really good against C. diff, right? So we talked about oral vancomycin being good for C. difficile. This is also going to be a good drug that can cover that. Note here, whereas with vancomycin, you can only use PO vancomycin, here you can actually use IV or PO. So there's some cases where we'll actually use like IV metronidazole plus oral vancomycin for like really severe C. diff infections for like patients in the ICU. This is one of those things where resistance to metronidazole is kind of increasing. And while this used to be sort of like the go-to drug, because it's pretty old and it's pretty inexpensive, we're seeing enough resistance patterns in adults to where actually vancomycin is starting to become more of the gold standard choice for treatment of that. But more often than not, though, I also see it a lot used for intra-abdominal infections in combination with something else. So, for instance, if we have like an appendicitis that they're worried about rupturing, they may go with a combination of like ceftriaxone, which has good gram-negative coverage, plus something like metronidazole together, so that we get anaerobes and gram-negatives and positives being covered there. So it's a good way to use it. You also see this used for a lot of like STIs and things like that, so it's a common one as well. In terms of side effects here, there is one notable one. This is like kind of really unique for Bacterium, with Flagyl, and this is one I'm going to underline and italicize because it's like an easy board style question. So, or it's like an easy question like preceptors can pimp you on. So if you know this one, you're going to be pretty well off here. So this is called a disulfram-like reaction with ethanol. And so basically what happens with ethanol is it undergoes sort of a two-step process of elimination. There's an enzyme called alcohol dehydrogenase, which converts ethanol, which you drink from like beer or wine or whatever. It converts into something called acetaldehyde. And then acetaldehyde is broken down by an enzyme called acetaldehyde dehydrogenase. So the namings of enzymes are not always the most creative. And it gets rid of the acetaldehyde. The problem, though, with drugs like disulfram, which is a drug we used or sometimes still used for alcohol abuse, and metronidazole, it actually inhibits that second step. It inhibits that enzyme called acetaldehyde dehydrogenase. And what that does is it leads to a buildup of acetaldehyde if you have someone who's consuming ethanol. Well, why is that a bad thing? Well, because of the fact that acetaldehyde itself is pretty irritating to the body. So you can end up seeing it causes a lot of like flushing, it causes a lot of sweating, nausea and vomiting. You feel very hot and flushed, and it's just a miserable sort of feeling. So the reason why we use disulfram for alcohol abuse is because, well, if I give it to someone who's abusing alcohol, this would make it so miserable for them to take the alcohol that they would just avoid it altogether, right? Not the best treatment because compliance with that is going to be pretty difficult to do. But this is sort of an ancillary effect of metronidazole you have to be cautious with because of the fact that if you have a patient who is taking this along with alcohol, they can have this very severe reaction. This is actually something interesting too, because some patients of certain ethnic descents will also have a genetic sort of predisposition to low expression of acetaldehyde dehydrogenase. So if you ever hear of something called like the Asian flush, that is something that happens occasionally with certain patients of Asian descent, where if they consume any alcohol, they end up getting this really red and flush sort of reaction. And that's actually the same thing here, is instead of inhibiting it through a drug, they just have a natural lack of the enzyme. Actually, in even topical administration of flagyl, we're going to see this with the derm lecture coming up in a little bit. Even topical administration of metronidazole and ethanol can actually cause a reaction, a really strong flushing reaction there. So be cautious. Make sure to tell patients not to take these together. You may think, well, if you have an infection, why would you want to drink? For some people, that's just their lifestyle, and that's just they need that alcohol because that's their dependency, and so it's not that uncommon. But make sure they are knowing to avoid that. Okay, real briefly, we'll talk about a fungal overview. Now, those are all the antibiotics we talked about that we're going to cover here. I do want to touch on a few antifungal drugs that will come up with more or less frequency here. Now, of course, just like we talked about specific targets that bacteria have that make our drugs more selective for them than for our human cells, we can find that the fungus sort of physiology is going to be different enough that we have specific targets that we can affect here. You're going to see, though, that there's kind of there's more, similarities between fungus and us in terms of cell targets that our drugs will focus on than there is between bacteria and us. And so, for whatever that says about people, and I guess I'm a fungi. I guess that makes it in some sense. But you'll see there's going to be some toxicities here that will affect us just like it does the fungus and make some of these drugs not perfect. You're going to see here that the fungus can be difficult to penetrate due to the fact that it has this kind of very structured cell wall along with this cell membrane here. And so this provides us several targets that we can focus on with our antifungal drugs here. And so we're going to see that one of the big targets is going to be something called ergosterol, which is an important component of the cell membrane here. We can also see that the cell wall is really rigid because of this chitin sort of structure here. It's kind of like armor almost for the fungal cell. And so we're going to see that it is, along with things like, different ribosomes and things like that, we need totally different drugs than what we would use for bacteria or what we want to treat, these fungal infections with. So, what type of patients get fungal infections? This is not as common as bacterial infections, but it can depend on sort of a lot of comorbidities patients may have. So, for instance, if someone had significant burns, or if they have like an indwelling catheter, or some kind of loss of typical physiologic barriers, that can lead to some fungi actually getting in and causing infection. Or if they have like a depressed immune system, frequently it's not cancer that kills some of these patients here. It's actually the secondary infections they get with viruses, with bacteria, and definitely with fungus is where you can find these patients who have severe immunodeficiency can die, is because we just can't treat the fungal infections they have developed because their immune system is so poor. Even things like diabetes and can lead to increased fungal growth. You can see things like warm, moist environments. So if you have someone who has like athlete's foot, they're wearing a shoe with a sweaty sock most of the day, or diaper rash, very common sites for fungal infections here. Most of them can involve the skin, especially when you see more like outpatient kind of stuff. But the ones that become systemic can be quite difficult to treat. And this is more likely to occur in those patients who are immunocompromised. That's where it becomes a challenge. So, and again, there's a lot of variety of fungus that are out there. I'm not going to get into the super specific ones here in terms of like which drugs cover what. Just know that when I'm talking about this, that depending on where the infection is, can lead you to think of certain types of fungus versus other sites. So for instance, if like the hair and the nails, you're going to find a different sort of spectrum of fungus than you would, say, for instance, with like stuff that would affect the internal organs, for instance. So, I can get into more detail on this, but this is kind of outside of our scope right now. Here's a bit of the drugs I want to cover, though, when we get into this in just a few moments here. So you can kind of refer back to this and the different classifications of them. So first off, I want to talk about drugs that kind of work on the cell membrane here. So most of these are going to work on the cell membrane. They're going to work on things like ergosterol. And again, this is kind of similar to the cell wall active antibiotics we looked at, where by disrupting the cell wall, you're going to be able to cause leakage of contents, and that leads to cell death. And this is no different than what we're going to see with the cell membrane of the fungus here. And then similarly, we can have some drugs that actually can affect that cell wall, not the cell membrane, and that can lead to, again, enough structural instability that leads to fungal cell death. And then we can even have some drugs work on cell division specifically. So things like griseofulvin, we'll see can actually affect the microtubules, which I'll mention here in just a few moments. So getting into specific antifungals here, real briefly. First one I want to talk about is called amphotericin B. This is something you're going to see more like on the inpatient side for more invasive fungal infections here. This is an interesting drug. If you kind of look at the structure here, it's a very long sort of planar structure. What it's able to do is actually inserts itself into the ergosterol and forms this membrane here. It forms a hole where it's basically things can leak out of. And that leads to things like potassium and magnesium leaking out of the fungal cell, which eventually leads to death of that fungal cell. Because again, if you were to leak out all of your potassium and magnesium, you wouldn't last very long either, as it turns out. That's important because of a lot of the issues we're going to see with the side effects this is going to cause. This is a pretty nasty drug. Some people often call this amphoterrible B because of such nasty effects that it has. But it's good because it has a lot of wide range of different types of fungus that it'll treat. However, we really like to hold off on using it until we have someone who has like a really severe systemic infection. One also interesting thing too is you have to watch out with its infusions. We actually infuse this drug over 4 hours, which is a really long time in the sense of like inpatient hospital time. And it's a lot of it due to like these reactions that it has due to when you infuse it too quickly, you release a lot of things like tumor necrosis factor and interleukin 1, which are really strong inflammatory cytokines. And so that leads to a lot of like fevers and chills and things like that. And so oftentimes what we're going to do is actually pre-treat patients. And so again, this is not an allergic reaction necessarily. It's more of this sort of inflammatory response you're going to see here. And so we can treat this almost like an anaphylactic reaction. And so in some cases, we'll give patients things like acetaminophen, which we know is an antipyretic. We can use things like antihistamines and corticosteroids. We'll cover this in more detail when we get into pulmonology and talk about anaphylactic reactions. But just know that these classes of drugs here are very good for helping to suppress inflammation, right? Now, as I mentioned, we don't like it from a side effect profile because it causes a lot of damage to human cells as well, especially in the kidneys, where it can actually cause a lot of electrolyte disturbances like leaking out potassium and magnesium, which can be significant effects here. So you got to watch their CBC or on their CMP, making sure that their electrolytes are going to stay in check there and replace as necessary. You can also see hypotension develop here. You can cause a direct kidney injury like uremia and decreased filtration. And so what we can do to try to avoid this is to try to hydrate the patient as best we can. So in addition to giving the drug over like a 4-hour period, we're like flushing them out with as much saline as we can. And that helps to sort of hydrate the kidneys and prevents the drugs from sort of accumulating in there and causing more damage, right? Now, sort of on the flip side of amphotericin B is something called nystatin, which has the same mechanism here. But what's interesting is that this has actually no oral bioavailability. And so by doing that, this is a very good drug we can use either topically or orally because it actually does not get absorbed at all. So this is typically used for things like, if you ever see like nystatin cream, this is good for like diaper rash and things like that. This is also really good for something called thrush, where if you get like a Candida albicans infection in the back of the throat, this is more so in patients who have either immunocompromisation or if you're taking like an inhaled steroid for asthma, which we'll talk about in pulmonology later on. This can be a really good drug to use because since with the thrush infection on the back of the throat, it's still kind of topical, so to speak. And so this is good because I can have a patient, swish and swallow this or swish and spit it out, and it gets good penetration of the fungus that's right there in the back of the throat, but it doesn't get absorbed, so it doesn't really cause any of these same side effects as amphotericin B does, right? And so we don't really have any other means of giving this systemically, so it's good for topical and oral candidiasis. Those are the best thing for it. All right, now switching gears and going with a different mechanism here, we're going to see the imidazoles and triazoles all have a similar mechanism here, and they're actually inhibiting fungal CYP450, and that prevents the conversion of a product called linosterol into ergosterol, which we said was a pretty important component of that fungal cell membrane there. Now, when looking at this, you're thinking, okay, well, it affects fungal CYP450. Could it affect our CYP450 as well? Well, the answer is yes, and you're going to see that's actually going to be a significant number of drug interactions you're going to run into with this, right? Wide range of different type of fungal infections this will treat. All of your tinnias can be treated here with this. A lot of your systemic fungal infections can be managed with this. Very handy from that standpoint. So we're going to use this for a lot of different things, and this might be kind of the first line for a lot of fungal infections. Ketoconazole is probably common one you're going to run into, especially from a topical standpoint. You may see that quite often, but can be used systemically as well. In general, nausea, vomiting, anorexia is pretty common with all these drugs here, but note significant inhibition of CYP3A4, right? Really strong inhibition here. If you were to take this with something like Eliquis, very significant risk for bleeding would be there. So you want to be really cautious when adding any of these azole antifungals in addition to things that are metabolized through CYP3A4. Sometimes we can get around this by like inhibiting or lowering the dose of something like Eliquis we would use. Sometimes we have to maybe just not use this type of antifungal altogether. It just depends on the situation. More common, what you're going to run into is fluconazole or diflucan. You'll see this used a lot for like vaginal fungal infections. Sometimes you'll see like vaginal tablets of fluconazole being used, oral tablets, things like that. Very good. It's also useful for like CNS infections. This is more often seen in patients who have like significant immunocompromisation leading to like fungal CNS infections like cryptococcal meningitis. So this can be useful for treating that due to this penetration. Usually CNS infections are really difficult to penetrate into. Again, note 3A4 inhibition, very strong inhibition there can lead to significant increases in other drugs that are substrates of CYP3A4, right? But nothing real special other than that. We have some newer ones after fluconazole, things like voriconazole. This is actually a derivative of that, and it gets some additional effects in terms of kind of more resistant fungus that it can treat there. So it's helpful for that. And even in some cases, actually replacing amphotericin B for some of the more systemic things like aspergillus infections and whatnot. But even wider CYP enzyme inhibition, not just 3A4, but now we have like things like 2C19 and 2C9 being affected, right? And what drug do we see that gets metabolized by both of those? Well, it's warfarin. So increased bleeding risk significantly with something like warfarin if you had to combine these two together. So you want to be really careful with that. This one's available IV and PO. It's kind of interesting though that the IV product, we like to get patients off of the IV product as best we can, because in order to get voriconazole into solution, we have to combine it with something called a cyclodextrin, which is kind of like a product that's a circular structure that the drug itself can kind of fit in the middle of. If you ever seen that movie Interstellar, I always think about that, where like the spaceship was right in the middle and they had this like kind of ring of other like little ancillary spaceships around it. It looks kind of like that. And so it is able to keep it in solution, but that cyclodextrin can actually build up in patients with renal failure and can lead to some toxicity. So you want to be cautious with that and just use PO if possible. Actually, cyclodextrins, if you've ever used a product called Febreze, that's how Febreze makes things smell better. It actually as a cyclodextrin that will encapsulate smelly particles, which is why also it doesn't get rid of those smelly particles, because eventually the Febreze goes away and then the smelly stuff is still around. So while guys may like to use it to help their room smell better, it does not provide a permanent benefit. You should probably just clean your room if anything. Paige is asking, are there some problems with fluconazole running into resistance from a fungi? Yeah, I know what you mean. In some cases, yeah. So for instance, there may be cases where and again, in terms of like getting cultures, like it's difficult to get a fungal culture because they're more difficult to grow. They take longer, and so you may find that it takes a while to get those cultures back. But if you have a patient who's on fluconazole and they don't seem to be improving over that period of time, you may consider switching it up and trying something a little stronger, perhaps a different mechanism entirely in some cases, maybe switching to like amphotericin B or some other ones we'll talk about in a moment here. So it just depends on the situation, but yeah, there could be some resistance for sure. In terms of imidazole derivatives, there's a ton of them that are out there for topical use, and you'll see these used a lot for things like yeast infections and things like that. Many of these are over the counter, so I just highlighted a few here that I think are probably more common you're going to run into, just based on like brand names and things like that. But things like clotrimazole, miconazole, monostat 3, 5, and 7, depending on how long you want to treat it for. Iconazole, things like that. A lot of these are over the counter. You can go and buy from the store and use to treat like vaginal yeast infections and things like that. So pretty common ones you'll run into. If I'm going to ask a test question on one of these, it'll be off of the ones I highlight off just this list, and then the ones I mentioned in previous slides here. So just FYI. Grizzly fulvin's another common one you're going to see used like an urgent care, family practice sort of standpoint. This is helpful for treatment of infections, fungal infections in the skin, hair and the nails. So you'll see this used a lot for things like, onychomycosis. You'll see this used a lot for scalp infections here. Keep in mind, though, that these infections take a long time to treat. So you may have a patient who's on griseofulvin anywhere from 1 to 12 months. And so obviously compliance is going to be a big issue with these, and making sure patients take all of it because frequently they stop early and then they don't continue, and then the infection comes right back, right? So especially the more distal you get from sort of the central circulation, like the toenails, they take a long time to treat, unfortunately. This is an interesting way that it works. It actually prevents dermatophytes from dividing, because if you go back to your undergrad biology, if you remember the cell cycle, prophase, metaphase, anaphase, telophase, all that. If you recall, towards the end of the cycle there, all of the chromosomes have lined up down the center of the cell, and then you have the mitotic spindles that pull them apart, and then they make the two new cells. This prevents that from happening, and so basically it arrests cell mitosis and prevents that fungus from duplicating, and so that way it helps to kind of curtail that and allows the host immune system to come in and kind of continue the work of getting rid of that fungus, which is helpful. Use it quite frequently on an outpatient basis here. Minimal side effects for the most part, maybe some induction of CYP2C9. This is important too because it may actually make things like warfarin less effective, because it induces those enzymes and would have it metabolize warfarin more effectively, so that can be an issue there. Most often, though, we tell them to have it with a high-fat meal because that helps it to absorb better. Make sure they're taking it consistently, because otherwise that infection is going to come right back. A few last ones here, things like, naphthene, terbinafine. These are common things you'll find over the counter as well, used for onychomycoses. This is where you get like your, Naphthene and Lamisil and products like that. So again, long treatment time, fingers 6 to 12 weeks, which is a long time for any patient to take a drug for. And again, for toenail stuff, up to 12 months. So really got to watch that compliance there. So that's it for this section. About the first hour here. Let's see how far I can get into the derm section. So this should cover everything you need for that quiz that's posted up for this week, right? And again, this is similar to the last quiz. It's just getting you into the idea of like, what are the things that I think are important? What are some things I want you to focus on? Again, it's not all inclusive, but the point is to get you thinking about how to study for the next exam, because the bugs and drugs can be difficult just due to the volume of medications we've hit there. So I do want you to sort of take that. You can take as many times as you want, just to get a feel for types of things I'm looking for. Maybe not specific questions I'm going to ask, but I'm not going to put matching onto an exam, but just to give you an idea of what I'm thinking about, okay? All right. There's no questions on the sticky board that I can see. As you can tell, I'm in the outer voids of space here, but trying to social distance from most everyone. All right, no questions. I'm going to continue on. Start talking about our dermatologic medications here. So talking about our derm stuff. So getting into derm, let's talk about some of the unique points of pharmacology that you'll need to know to kind of think about topically administered medications here. And again, when I'm talking about topical here, I'm talking about applied directly to the skin. One of the things you're going to find is that depending on drug characteristics, drug penetration can be quite variable. And again, I'm not going to be talking about drugs that are given topically with the intent of getting systemic effects. So I'm talking about like patches and things like that you administer. Mainly talking about dermatologic concerns, acne and eczema and things like that. But depending on where you're applying the medication, you can find systemic absorption, which can lead to either intended or unintended effects, as the case may be. And so a lot of it is dependent on where you put it, how much you're putting on, the concentration of the drug, just the penetration of itself based off of how lipophilic it is. A lot of things are going to make a difference here. So for the first thing here includes like how permeable the skin is and where you're putting it. So for instance, areas of thin skin or thinner membranes are going to have an easier time crossing than areas where it has thick skin. Sorry, might bother me, but so for instance, if I were to apply something to the axilla, you're going to get better penetration because that's relatively thin skin, as opposed to if I applied it to like the hands, right? Because the hands are more calloused and it's thicker, have a more difficult time crossing there. So those are things that are important, because where you put it can predispose the patient to absorbing more of the drug than maybe what you intended, and it can lead to significant, systemic effects, right? Which may be fine, maybe not fine, depending on the case there. You can also find that depending on the concentration, that you can overcome some degree of resistance. And again, the bigger the difference in concentration of the drug from outside of the membrane to the inside can help to facilitate that transfer in, right? Just via natural diffusion. And so by increasing the concentration of the drug, that can help to enhance that transfer. So for instance, if I give like a corticosteroid that the patient's resistant to, I can increase the concentration of it and have better penetration through the skin, right? Now, you will find also that the skin is helpful because it can actually serve as a reservoir for the drugs and have what they call a depot effect, right? So I always think about the Home Depot holds a bunch of stuff for helping your house out. Well, the skin can hold a bunch of medication that can lead to sort of prolonged sort of effect for happening. So anytime you see a depot of something, it means it's just a spot that's holding on to an amount of drug that can be absorbed through a period of time. And so in these cases here, you may apply a drug to the skin and, maybe it takes a few days to really kind of kick in and have full effects, but then you stop giving the medication. Well, that drug is still sitting there in the skin and it can have, a period of time where it's still kind of being absorbed slowly. So even if you stop the medication, does not mean that the effects are going to stop immediately as well. This may also help out with prolonging the effects of the drug, such that like, a short-acting medication I can maybe only give one time daily and help with compliance, right? The next thing we'll talk about is vehicles and occlusion. In vehicles, I'm not talking about like your car or your skateboard or whatever. Vehicles, I mean, is what is that drug being put into in order to keep it in solution, in order to keep it in a way that can be dispersed over the skin. I'm talking about like ointments and creams and lotions and things like that. That's kind of what I'm referring to in the vehicle. And also occlusion means like how long is that product, that vehicle, going to be sticking around for on the skin. Things that are more water-based are very easy to wash away and they don't stick around for as long. Versus if you were to think about something like Vaseline, which is petroleum jelly, or white petroleum jelly, that is very oily. It's very sort of, greasy. It's going to stick on the skin for much longer, which, may not be great from a, feel perspective for the patient, but it may stick around for longer and have longer therapeutic effects. Also, the more occlusive something is, so for instance, if I were to put a wrap around something, if I were to apply like a cream or a lotion to the skin, and then were to wrap a bandage around it, for instance, or like a plastic wrap or something like that, that increases that occlusion because it keeps the drug there for longer and may lead to better effects, but also can lead to toxicity in some cases there. So you may need to be thinking about that sort of thing. So also to consider too is, what's the solubility of the drug in the vehicle. If it's not soluble, then it's not really going to get good absorption. How hydrated is that stratum corneum, and how hydrating is the what I'm using. Now, again, one thing I'll mention here is that, in terms of derm, a lot of PAs that I know go into derm, and that's like what they just love, and that's their thing, and I love them for it. And so I may make some broad generalizations about derm stuff, and maybe if you work in a derm office, you're like, well, that's not right in every single case. Again, derm is not my area of expertise by any means here, so I can give you sort of the basics, but, I've not been working in derm for the past 10 years. I've been working in pediatrics and emergency medicine and toxicology. I can tell you a lot about that. So every teacher is going to have their blind spots here. But, one of the things you'll hear about is sort of a broad caveat with derm, which may not always be true, is that if it's wet, you want to dry it, and if it's dry, you want to wet it, right? And so what I mean by that is that in some cases, if you have like really dry, scaly patches of skin, maybe due to eczema or something like that, well, being able to hydrate that stratum corneum can actually help to enhance penetration. We're going to find that different products may be more or less moisturizing. So we'll look at a comparison of that in a moment here. And then also to consider like how stable is the drug in the vehicle itself. Typically, when you put drugs into some kind of liquid medium, stability is going to be shortened. That's why a lot of the IV products that you run into, you're going to see come as that little freeze-dried powder that you have to reconstitute. A lot of this due to the fact that it becomes more stable when it does not have water to interact with. And so most, topical products are going to come in some sort of vehicle, and that's going to affect the stability. So that may lead it to not be as good for as long, depending on the situation. So just as a general overview here, if you're looking at different dermatologic vehicles, you can kind of go from sort of most drying to least drying, or say most moisturizing down here at the bottom. And so a lot of this has to do with like the water content or the oil content of the vehicle. It also can depend on the alcohol content. You're going to find that anything that contains alcohol tends to be drying because it tends to evaporate very quickly and can take some water along with that. And so things like tinctures, which do have a significant alcohol in component, will tend to be more drying, which is good for things like oozing or crusting and things like that. Versus if I was to use something more like a cream or an ointment, that's better for more really dry, scaly sort of skin, and helps to enhance, moisturization of the skin and enhances drug penetration too. And so here's sort of a comparison chart you can kind of look back at. I'm not going to quiz you on specific percentages by any means, but just in general, if you're comparing like a cream versus an ointment, like what's kind of the big difference here? Well, with a cream, it's an oil and water emulsion versus ointments, it's a water and oil emulsion. You're like, what does that mean? Well, it has to do with the actual content of the water, and what is kind of more predominant. So, for instance, an emulsion is a mixture of two things that normally are not soluble together, or are not miscible together. And so you are kind of forming a blend here, even though knowing that they don't really mix all that well. So oil and water, obviously don't normally mix, but we can add some things that can help out with that. So anyway, and you're looking at sort of how solubilizing, the component is. More water is going to be here in the creams versus an ointment is going to be more oil or more fat, kind of compounds there. And so that has a big effect on how the products actually feel, right? So if anyone's ever felt like petroleum jelly or Vaseline or something like that, it leaves a really kind of like thick, oily sort of film on the skin that feels kind of greasy, which may not be, ideal for the patients, but it can be useful, it can be kind of protective on the skin, can lead to higher occlusion, which can help the drug to stay around for longer, things like that. Versus with a cream, it's going to be able to spread more easily, it can be washed off more easily, it doesn't leave that greasy feel, it's not going to stain your clothes and things like that, but it has relatively low occlusion, so it may not stick around for as long, right? So there's good things and there's bad things about all of these. And so it just depends on kind of what's going on with the patient, see what they kind of need there. Typically with like, lotions and gels or foams, there's gonna be higher water contents than even what you would see in a cream, so even less occlusion here. But maybe useful for things like, applying to the scalp, right? I probably wouldn't want to apply Vaseline into the scalp unless I wanted the patient's hair to stick like straight up or something. It probably has pretty good hold, but it's probably not going to feel too good for the patient, especially when they're washing it later on. So using things like higher water content or maybe alcohol content can be useful here, and we more on the drawing side of things. So those are kind of the basics of dermatologic principles here. Now I want to get into specific medications and specific use cases here. So the first thing we'll talk about is acne. Acne is going to be a pretty kind of wide-ranging disease. It's kind of different for many different patients here, but it's multifactorial at its base. There can be racial components, genetic components, hormones, diet. Stress can have some role to play here. You may find your adventures in PA school may lead to some flare-ups of acne depending on how stressed out you are. Cortisol plays a role. But when it comes down to the actual pathophysiology here, we're going to see there's four major factors here that go into it. Basically, what happens, and ultimately this comes down to being sort of an infectious disease sort of process here, right? And what we're going to find is that you're going to have, these hair follicles that will be producing some amount of sebum, right? Which is a normal, compound that's going to be making itself. What happens though is that you end up getting this increased sebum production that occurs, whether due to hormones or stress or whatever, and that's going to lead to this kind of alteration of this keratinization process. And basically, and I'll show you a picture of what this looks like in a moment. You get this hyperproliferation of the ductal epidermis, and what that does is causes an occlusion, right? So producing this extra sebum causes increased keratinization. You're causing occlusion of that follicle, and that then leads to this nice anaerobic environment where you can have something called propionum bacterium acnes actually start to proliferate. So they get colonized by these bacteria, and then your body senses that as an infection, and that leads to an inflammatory response. So things get red and inflamed and edematous. You can have inflammatory cells coming and trying to break down these bacteria, and that leads to pus formation and things like that. And so you can find this sort of cycle that occurs here, but these four steps are the main things we're going to be focusing on with our medications, and so that's the thing I'm going to be focusing on there. Now, certainly, there are different contributory factors here. So things like, having helmets or shoulder pads on for a teenager who's in football practice, for instance, can affect this. Or if someone has, for instance, excessive scrubbing or washing of the skin and actually strips the skin of a lot of oils and things like that that are typically protective, that can be an issue too, or even the season matters, right? Note here from a physiologic standpoint, the more stressed someone is, their risk for acne exacerbations can go up, mainly because stress is releasing more cortisol. Cortisol is a glucocorticoid that suppresses the immune system to some degree, to a mild degree, and that can lead for those propionibacterium to start to kind of proliferate more freely. It's not going to happen to everyone, but if you ever see someone who's like really stressed out and they have new pimples, like that could be related to that, right? And so again, here are sort of more details on what we're talking about in terms of the pathogenesis here. I think it's easier if I just kind of show you a picture where you can see here was what the hair follicle would look like with the sebaceous gland releasing sebum. What's going to happen here is that now you have some kind of plug that occurs here due to increased sebum production. Notice here they're going to have a lot of this like keratin and things like that building up, leading to even more of an occlusion, and that leads to that nice anaerobic environment where now the bacteria can start to grow and proliferate and colonize, and then that's going to lead to the inflammatory response starting to pick up, leading to trying to kill off those bacteria, leading to pus formation and things like that. And that's where you actually get sort of this nodule or cyst sort of starts to form here, as opposed to like some of these earlier comedone sort of stages here. So, and again, how much inflammation patients have may be very dependent on their particular disease state. Can be dependent on a lot of factors there. So, what's our goals here? Well, obviously, we want to try and manage this from a we look at this as something that kind of happens in cycles. There's going to be peaks and valleys in terms of severity of disease. And so when they're having a flare up, you want to increase your treatment. And then when they're kind of going back down to the sort of their baseline state, we can sort of manage them with more maintenance therapy. One of the caveats you're going to see with treatment for acne is that majority of these drugs here are going to be irritating to the skin. And so you want to use sort of the lowest concentration you can get away with. You want to use the lowest dose, the lowest fewest number of drugs you can. And so that's why you may find that as patients have a flare up, then we may kind of step up our therapy, but then we want to get it back down to as low intensity of therapy as we can in terms of concentration, in terms of number of drugs, all of that, to prevent those side effects from occurring there. Now, obviously, if we can try to limit, recurrences from happening here, if we could limit, any kind of long-term scarring or disfigurement, all that's going to be great. And of course, try to limit that psychological suffering patients may be experiencing along with that, because we all know that, especially when you're in your formative years, teenagers are pretty savage in terms of letting people know about all of their physical flaws. And so this can lead to some severe psychological issues for some patients, right? So we want to prevent that if we can. So what we're going to look at is trying to eliminate that follicular occlusion. That's kind of the main thing we're going to focus on. If we can prevent that from occurring, then we can prevent all those other steps from happening as well. And so, of course, we're going to be using combinations of pharm and non-pharmacologic therapy here, making sure that we're utilizing multiple mechanisms of action to help to be synergistic with one another. That's really the big thing to focus on there, is making sure we're looking for active synergy amongst our various medications here. And if we can, target multiple steps along that pathogenic pathway. So I'll talk about that in a moment here. Typically for more mild to moderate disease state mild to moderate acne, topical therapy is going to be preferred for the most part, especially when it's limited in terms of the location. If it's over just the face, for instance, that's easier to manage than if it's like the face and the back and the whole trunk, essentially. That's going to require a lot more topical application of medications that may not be reasonable. And so for more moderate, severe, or more diffuse disease, then we consider systemic therapy. And so I'll talk about what those options are here in just a little bit. So in terms of cleansing and non-pharmacologic therapy here, typically when we're using cleansers and soaps and things like that, there are surfactant systems. And just like if you ever, for instance, are cooking and you get some oil on your fingers, right? You get like some olive oil or something on your fingers. To get rid of that greasy sort of feel, you could use water, but that doesn't really do it all that too well. If you use soap, though, it helps to disperse those fats and oils. And so that's one thing you can do to help clean up your hands after you're cooking. Same thing can happen to your face if we're using soaps on there. However, you need to be cautious because of keeping a balance between being clean and versus over drying and irritating the skin. Because those fats and oils are helpful because they provide sort of a barrier to prevent, evaporation of water and things like that. And so over cleaning tends to dry out and irritate the skin. And soaps tend not always be the best products too, because the soaps tend to be basic in nature in terms of their pH. And so high pH can actually have some issues and actually inactivate some other drugs. So we'll find that's going to be an issue. And then once they're rinsed off, they don't really provide any lasting effect. Well, once they're gone, they're gone. And so overall, then you strike that balance, and we tell patients, don't do it too frequently, maybe like twice a day, and not to use like over excessive like scrubbing. You don't want to be like taking like a loofah to your face 4 times a day. It's just going to lead to a lot of irritation, right? Now, as I mentioned, topical therapy, it only is going to work to where you're applying it, and so it requires you applying it to the whole affected area, which is why it becomes challenging if you have someone who has a very diffuse, state of disease versus someone where it's only affecting like their face, for instance, here. And so, as I mentioned, most can cause skin irritation, so you do want to be cognizant of that, and that frequently leads to patient discontinuation. They say, well, man, these drugs are worse than the actual acne itself. Why am I going to keep taking this? And they'll discontinue it early. So, not great from that standpoint. So what we do to try to prevent that is we try to go as like low strength as possible, go low concentration, and then gradually increase, right? When you're thinking about treatment of acne, this is no one's going to die from acne anytime soon. So you have time to kind of start low and go slow, right? That's kind of a mantra you'll hear me talk about quite frequently, depending on the disease state. Now, if a patient's in VFib or VTAC, if you go low and go slow, your patient's going to be dead before your drugs become effective. But for acne, you got some time to play with, and so it's okay to try to find that balance between efficacy of the drugs and also how many side effects you're going to be inducing. Because again, a lot of these are going to be pretty irritating to the skin. And again, if you can use non-alcoholic solutions, that's going to be beneficial because that prevents a lot of the drying effects you can see with ethanol or alcohol being in your products. So here are sort of the 4 main pathologic steps here of acne development, and here's where the medications are going to be working at that we're going to be talking about specifically. Note here that various medications may work on multiple steps here, which is beneficial. If they can pull double duty, that's a good thing. And so I'd recommend doing that if possible, but we'll look at some of the places where these are going to be effective. Not all of them are going to be as effective as others depending on the patient's state here. So when you talk about like hormones, a lot of that can be very dependent on kind of what the patient's hormonal status is, right? And so we'll mention that in just a little bit. So first off, it's going to be benzoyl peroxide. Now, this is probably something many of your patients have already tried if they're coming in to get prescription medications from you, because a lot of the weaker varieties are available in a over-the-counter preparation. And that's really important to ask about what patients have already taken prior to coming in and seeing you, because if they've already taken benzoyl peroxide and you come in and say, well, let's try some benzoyl peroxide, and they say, well, that doesn't work for me. You said, no, we'll go try it anyway. They're not going to think you're a very good provider, right? So you need to see what they've already taken to see if maybe you need to change the concentration, maybe if you need to go with a different drug altogether, just depends, right? So anyway, what is benzoyl peroxide going to do? Well, basically it's going to penetrate through that stratum corneum. It gets converted into something called benzoic acid, which actually has good antibacterial activity against P. acnes here. It also provides sort of a peeling and comedolatic effect, so it helps to kind of strip some of that upper layers of the skin there to actually cause those comedones to sort of open up. They can then kind of breathe a little better, and that allows for more air to get in there and prevent the P. acnes from growing as much, right? As you might imagine, this can be irritating to the skin because it can cause peeling there, right? So it's not uncommon to see a lot of skin irritation associated with this, especially with higher concentrations, right? As I mentioned, start low concentration, maybe once daily, and then you can increase strength and frequency as tolerated by the patient. This may be over the course of weeks to months, depending on the situation, right? You'll frequently see these in combination with topical antibiotics as well, so things like erythromycin or clindamycin, so that's not uncommon to see there. And as I mentioned with the side effects, again, it's going to be irritating the skin. Definitely avoid contact with mucous membranes. So the mouth, the eyes especially, really make sure patients are washing their hands after utilizing this, because if they were to rub their eye or something, get that in there, it's gonna cause some issues, right? So don't want that to happen. Also, it can bleach their hair. So again, if you're applying close to the hairline, that can be an issue, and then it can bleach clothes as well. So probably not great to apply this light to the chest and then put on your favorite shirt. So probably not gonna be a good idea. Now, similar to benzoyl peroxide is another product called azelaic acid, or Azelx. And so this has kind of a similar mechanism probably to benzoyl peroxide. It has decent antimicrobial activity, but it also inhibits this conversion of testosterone to dihydrotestosterone. So most people have probably heard of testosterone before. as being sort of the main male sex hormone. It's an androgen, more broadly speaking, meaning it has sort of androgenic effects. It has a sort of anabolic effects and masculinizing effects. But what's interesting is testosterone itself, while it can do all those things in terms of causing masculine development and things like that. There's a stronger version of it, and so there's an enzyme we'll talk about later that can convert testosterone to DHT or dihydrotestosterone, and this is a way more potent androgen here, stronger than what you would see with testosterone. And so, in some cases, you may find that acne is sort of enhanced by high levels of testosterone. You always hear about bodybuilders getting a lot of acne as a result of using exogenous testosterone and things like that. Well, a lot of it can be related to the DHT that is formed sometimes if they were just taking straight testosterone. It depends on what they're taking, but loosely speaking, if you had someone who is in a hyper androgenic state, and they're producing a lot of DHT. So, for instance, like someone like PCOS or something, when they have like a high androgenic activity, this could be one of the reasons why they're having acne as bad as they are. And so, azelaic acid could have some additional benefit to prevent this from occurring. This is also an important process for when we talk about things like benign prostatic hyperplasia and BPH and prostate cancer. So, we'll talk about this later on in the urinary section. But just know that this is an additional side benefit of azelaic acid. And so again, skin irritation is going to be the biggest thing. We're going to run into this, and then note that with a lot of these over time, you're going to find that irritation tends to sort of subside. Not for everyone, but in general, it gets better with time. So like 6 to 8 weeks of continuous therapy should improve, but that's a long time for a lot of patients, and so they may discontinue early if they don't really feel like it's getting any better. It can also cause some hypopigmentation, which some people will use that for its benefit. If they have like a dark spot or something, they may try to treat that with azelaic acid. But also that can cause hypopigmentation of skin that you don't want to lighten. So it just depends there. All right. So, stepping up our game a little bit, going into our topical retinoids. Retinoic acid, otherwise known as tretinoin, is sort of it's an acid form of vitamin A. And while we don't know the full mechanism here, we do know what it does to the skin. And some of the things it does includes, correcting some of that follicular keratinization, so prevent sort of that occlusion from happening due to that, build up of keratin and sebum and all of that. It can help to reduce P. acnes counts, so it probably has some antibacterial activity there, and also helps to reduce inflammation. So you've had a patient who's been on something like benzoyl peroxide or azelaic acid, and it's just not working for them. This is often what you're going to step them up to, right? I think tretinoin is now available over the counter in the U.S. For a long time, it was not. We'll also look at some other varieties that are going to be a little bit stronger as well that are going to be prescription only. So it just depends on what form you're looking at. So typically for more non-inflammatory comedonal acne, this is a pretty good one, and it can also be used in combination with things like benzoyl peroxide. It just depends on how you're using them. And also you'll find this being used for some aesthetic purposes because it is sort of can cause hypopigmentation and can be used for wrinkles as well. So some people may like it for sort of its anti-aging quote unquote sort of properties there. Now, again, as we're stepping up our therapy, we're also going to get more irritation occurring here. So erythema, desquamation of the skin, burning, stinging, all of that. Some of this can be prevented by using things like emollients, right? Emollients is sort of a term for moisturizing products. So if you think about things like Aquaphor and things like that, that can be helpful to help sort of limit a lot of that kind of irritation to the skin after using a topical retinoid. I always like to tell people, it's like, yeah, Aquaphor you can get over the counter. That's okay. I like to use Aqua 5, sometimes even Aqua 6. That's the really good stuff. Just a joke because there's Aquaphor, there's no such thing as Aqua 5 or 6. But also, again, being in Florida, problem is, you can see a lot of increased photosensitivity and risk for severe sunburn. But again, specifically in the areas where you're applying this, so make sure they're using high SPF sunblock, using skin coverings and things like that to prevent this from occurring. Another thing too, you want to avoid during pregnancy. In general, just like we saw with warfarin and being very teratogenic because it affects vitamin K, this affects vitamin A, right? And so anything affecting fat-soluble vitamins, medication-wise, tends to be very teratogenic. So anything affecting A, D, E, and K, ADEC, for your fat-soluble vitamins, you don't want to mess with those in pregnancy because it can lead to teratogenicity, can lead to fetal death. It's not great. So definitely avoid during pregnancy for the most part. And again, you're treating teenagers who may be at risk for developing pregnancies, right? So you want to be cautious with that and educate as appropriate. So three main ones you're going to run into, as I mentioned, is going to be tretinoin. This one's actually photolabile, which means that you don't want to put it on during the daytime because the sun's rays can actually inactivate it. So apply nightly. That can actually improve its benefits there. And you also don't want to use tretinoin at the same time as benzoyl peroxide because that benzoyl peroxide will inactivate the tretinoin as well. So this may be a case here we may see patients using like benzoyl peroxide in the morning and then tretinoin at nighttime, for instance, right? You could step it up a little bit, and then we have things like adapalene, which is going to be prescription only, I believe. And this is stable in sunlight and also stable benzoyl peroxide. It tends to be a little less irritating than tretinoin itself, so that could be another benefit there. And then for even some severe cases, we have a product called tazarotene, which is like a third generation retinoid, typically used for like more severe cases of acne or like psoriasis, where you're more looking for the anti-inflammatory sort of effects there. And sometimes we'll even use it for like in combination with topical steroids for like really severe inflammation. So most patients are not going to get up to this point here. They'll probably either be using like the tretinoin or the adapalene for the most part. Now, we can also use some topical antibiotics as well. These can be handy for helping to prevent bacterial proliferation from occurring here. So things like clindamycin and erythromycin tend to have the best activity. Now, again, you may see some resistance over time, but again, when you're topically applying antibiotics, you're getting such high concentrations at the skin that it helps to prevent some of that resistance. But, you know, again, over a long enough scale of time, you can see some issues there. The other benefits too of using topical antibiotics is it helps to limit any kind of systemic effects. These don't really get absorbed all that well, and thus very limited systemic effects there. Paige is asking, what's the time frame for a lot of these medications? Should we advise patients to try for days, weeks, months before giving up? Yeah, so you may see in terms of like efficacy, it could take a couple of weeks before you start to really see them really have their main benefits, especially depending on how severe it is when they're coming in. You know, so I would say within, you know, a week or two, you should start to see some improvements in terms of the acne symptoms. The side effects are going to be immediate though, right? So the irritation effects will be certainly within the first few days, but those may take like 6 to 8 weeks before they really sort of, you know, die down to their sort of lowest points. So you may say, let's try it for, you know, say 2 to 3 months, depending on the situation, depending on what they've tried. You know, after a few weeks, if they're not seeing any improvements, then that may lead you to say, well, let's go ahead and try something different. Let's either up the dose, let's try a different medication altogether. Just depends on the situation. And again, this is not something I deal with on a day-to-day basis. So if you talk to someone who works in derm more consistently, they may be able to tell you something a little different there, right? I'll show you an example of a chart at the end here that will give you some better ideas too in terms of like treatment times and when we're gonna like start to step up therapy, things like that. Now, what do you do when topical treatment isn't enough? This is where you can get into oral therapy for acne. And so the first thing you're going to see here is our systemic retinoids. So kind of switching over from, you know, something like topical tretinoin over to isotretinoin, which is used orally. You can see here this one's effective in about 1 to 3 months. This one's really important because while it is really, really effective for acne, and some of you maybe even taken this in your formative years, you'll see there's a lot of side effects associated with it, and a lot of issues. So one of the big things that is absolutely contraindicated in patients who are pregnant or breastfeeding, because again, this is going to severely affect vitamin A in a developing fetus or in an infant, and so you do not want to have any contamination there occur. And even there's some risk for male patients taking it. It could have some transference through the semen to a female patient. They even say men should avoid it too. So how do we try to encourage that? Well, we have something called a REMS program. It's called Risk Evaluation and Mitigation Strategy. And some drugs that have like really profound side effects or teratogenic effects, you know, the FDA will say, okay, we need to have a REMS program in place to make sure that, you know, patients aren't getting pregnant while taking this drug. And so the system they came up with for isotretinoin specifically is called iPledge. You know, committed to pregnancy prevention is probably, I would like to say I'm doing the same thing for my children whenever they become teenagers. But what this is a program where the provider has to be registered with them, the patient has to be registered, and then the pharmacy has to be registered with them as well. And so basically what this does is, one, it includes a lot of education about using contraception, about not getting pregnant, about what can happen if they get pregnant while on the medication. It also includes for female patients or childbearing potential, getting pregnancy tests done regularly to make sure that they are not becoming pregnant while taking the drug, all of that sort of stuff. And so all of that is done to where, for instance, if the patient's coming in getting a new script for their isotretinoin, and you as a provider just write it for them without doing the proper checks and logging their pregnancy tests and stuff, and they come to the pharmacy to pick it up, I'll run it through the iPledge system, and it'll say, nope, you can't give it to them because they didn't have their pregnancy test done recently enough to say, okay, you can have it. So a lot of checks in place to prevent that from happening, which is kind of unique. We haven't really seen any other drugs have such a significant system put in place to make sure patients are compliant. But other things that can happen here too, again, with topically applied tretinoin, for instance, it's only going to affect the areas where you're applying it. With with oral isotretinoin, this is going to affect the entire body. So the entire body can potentially be affected here. Cause significant erythema, pruritus, scaling can occur here. The eyes can be affected because if you recall back from your physiology, vitamin A in the eyes is really important for how your rods and cones are functioning. So this can cause photophobia or light avoidance, things like that. They can develop things like headaches, alopecia, brittle nails, because vitamin A is important for production of things like your nails and your hair. You can even see worsening signs or developing signs of depression. There's another case here where you want to make sure that whoever is around the patient most frequently to monitor for things like new signs of depression. They become more withdrawn from their activities normally, or they're just starting to see anything different. You want to kind of catch that early because there have been rare cases of patients who have become clinically depressed from after taking isotretinoin, and there is a risk for suicidality, so you want to be really cautious and monitor for that, right? So we could also use systemic antibiotics, and so again, this is for more diffuse disease, more extensive, more difficult to treat disease. So this is not be something you want to jump to initially, but if if it's more body wide, we don't want to be applying topical clindamycin over half their body. This is a more sort of efficient way to do that. And so the tetracyclines are going to be far away the most common ones because these are fairly old drugs. They're cheap, relatively effective, but remember some of the downsides of using the tetracyclines. Really, any of them can be used. Most of them are safe and effective. Most are going to be inexpensive, but recall that things like for instance, patients who are less than 8, acne is probably not going to be a big issue for them, but you'd want to avoid kind of continuous use for them and avoid in pregnant patients too, because it can affect the skeletal development in the fetus. You want to be cautious with that. Occasionally, you see things like Bactrim or azithromycin or Cipro being used here if maybe they had like an allergy and they couldn't take tetracyclines, or if they had some kind of side effect where they were not able to tolerate it, you could use it as backup. But again, these are going to be far and away the most common ones you're going to see used for acne specifically. So if you ever see someone who's getting a prescription for an antibiotic, but there's no stop time on it, it could be related to a chronic issue of something like acne, for instance. A few other therapies you may be using less commonly include things like salicylic acid, which is a derivative of aspirin. Aspirin's acetyl salicylic acid, but this is used frequently for things like wart removals because it has a very strong keratinolytic effect. It can also be used for acne occasionally. Again, I don't know if there's a whole lot of evidence to support its use, but some patients may try this if they're looking for like a non-prescription based product to use for that. Some anti-androgens can be helpful here. As I mentioned before, like azelaic acid, if you can prevent androgenic activity, that can really help to prevent acne in some patients, or can help to start to reduce the effects. There's an oral product here, which is also available topically. It's called spironolactone. This is actually a diuretic we're going to talk about later on, but it actually has some anti-androgen activity, and so it can be beneficial from that standpoint if the acne the patient is experiencing is a result of sort of this hyperandrogenic effect, right? So if they have a relatively low testosterone and DHT activity, then this is not going to be all that useful. But if it's a high level, and that's what's causing a lot of the acne, then this may be worth trying, right? And in some cases, oral contraceptives can be useful here as well. So typically this includes an estrogen, a synthetic estrogen called ethinyl estradiol, and then usually with some sort of progesterone on top of that. And so this is another thing too, where it depends on sort of the hormonal balance of your patient. You may find that for some patients starting oral contraceptives, it worsens their acne. For some people, it helps it. So it's entirely dependent on the patient. You can try it, see how it works. Again, if they are going to be taking isotretinoin, they're probably going to be taking oral contraceptives as well, right? Not always, but in a lot of cases. So it just depends on the situation. Maybe useful, maybe not. Right? So let's look at sort of the stepwise approach here you can go through. So again, depending on the severity of the acne and how you could sort of classify it as type 1, 2, 3, or 4, which I'm not going to ask you to describe it on a test or something like that. But the big thing to note here is you want to go sort of with a stepwise approach. Figure out what the patient's already tried, and then figure out if that's not working, what do you step up to, right? Or if you say you've bumped up a level and you've gotten things under control, what do you scale down to, right? So be able to go kind of either direction here. So for instance, if they're starting out early with like a type 1, very kind of minimal, milder sort of set of acne, well, then maybe like a topical retinoid is fine, right? Maybe in combination with benzoyl peroxide, the patient's probably using anyway on an outpatient, over-the-counter sort of basis there. And then again, you see how they respond. If it clears up, then maybe you can taper down therapy to either lower concentrations, fewer administrations, or maybe you can stop it altogether, perhaps, right? If they don't have a response in 3 months, though, that's where you need to consider stepping it up, right? So at this point here is where you consider adding on something else, like maybe a topical antibiotic, right? And then you see how it goes. At this point here, where that still things are not all that effective, this is where you can start to consider either systemic antibiotics, which are relatively safe for the most part, maybe in combination with a topical retinoid, right? So still using some topical effects here. If those are not working, right, and you'll typically see like the systemic antibiotics are going to be like a 4 to 6 month period or so, because again, you don't want them to be on it like constantly necessarily, but you can see how that goes. If that's still not effective, that's where we start to consider things like the oral retinoid, right? So the isotretinoin. Typically, what you're going to find is that if you can hold off on using oral isotretinoin just due to the severity of the side effects you can see with that, it's always going to be beneficial, right? Like I said, it's a very good drug at what it does, but if you don't need it, then don't use it, right? So if you can try maybe a short period of time where they're on it and then scale back to something else, that's always beneficial. Just because the side effects are so nasty, you have to go through the iPledge program and all that kind of stuff, so it's not great. So all things to consider. But if I tell you, like on a test question, a patient comes in, they've been trying over-the-counter benzoyl peroxide, what would be the next thing you'd want to try? Well, then something like topical tretinoin would be a good option, right? Or if I come in and they're saying they're taking, they've been using tretinoin topically plus benzoyl peroxide plus topical clindamycin for the past 6 months, and they're not seeing any improvements, what do you want to step them up to? And that's where you consider like a systemic antibiotic, right? So have an idea of your mind, like how you would kind of step through these different drugs and when you'd add one, when you might take it away, things like that based off this chart can be helpful. So I got a few more minutes here, so I'll see what I can get through. But next off, we have atopic dermatitis. This is more referring just to kind of dermatitis in general for the most part. So kind of focusing on inflammation of the skin and how we can treat that. This is where we're going to get into a lot of our steroids and things like that, right? And again, with a lot of patients with dermatitis, frequently you'll see this called eczema. It's kind of a chronic sort of inflammatory disorder with pruritus. Typically, you can also see this in combination with things like asthma and rhinoconjunctivitis too. In a lot of cases here, but we're going to see there's a dysfunction in the skin barrier. So if we can help to manage this, this is going to be very beneficial in helping our patients out. And you can see here a lot of the different kind of presentations patients will show up with, but typically pruritus is going to sort of be the big one here. If you were to see, also like do allergy skin testing as well, or do blood testing, you'd see increased levels of IgE, which is evidence of increased inflammation. You'd also see like positive allergy skin tests, and in general, patients who are allergic to one thing tend to be more likely to be allergic to other things as well. So kind of you'll find patients who have allergy lists that includes like, pet dander and dandelion and grass, and they'll have like a whole list here because they went through some kind of allergy testing and they just happen to be allergic to a lot of different stuff. So what do we want to do for these patients? We'll typically provide symptomatic relief for them. Obviously, try to alleviate the pruritus and the inflammation. Again, frequently patients can give themselves an infection because they're scratching so much that they are disrupting that skin barrier and can lead to infection that can occur there. And if we can, try to prevent kind of future exacerbations and treat any secondary infections. That's kind of what we're going to focus on here going forward. In terms of non-pharmacologic therapy you can do for these patients here, especially with kids who have eczema, because this is pretty common. Some things you can do includes, things like lukewarm baths and because really hot baths can sometimes exacerbate the eczema. You can do things like applying lotion or emollients after bathing. They can be helpful here. Keep the skin nice and hydrated and non-irritated. Keep their fingernails short to make sure they can't scratch it too bad there. And then sometimes we'll even give them like sedating antihistamines like Benadryl or something to help prevent some of that nighttime itching from happening there. And obviously, the biggest thing too, if you can remove or identify the irritants and allergens, that's a huge thing. So if they have pets or something, and that's what's exacerbating it, it might be time to get rid of Spot or Rover or whoever, So it may not always be possible, but that's something to consider. And of course, always a good idea to maintain good hydration, keep the skin nice and hydrated. That will help to prevent some of that irritation. So let's talk about our pharmacologic therapy, because this is your pharm class and is what you paid for. Topical corticosteroids here are going to be the gold standard, right? So these are going to be anti-inflammatory in nature. We're going to see there's a lot of them that are out there, so I'm going to talk about some caveats with these. How we choose our steroid is going to be dependent on the severity of the inflammation and also the site of disease, so kind of where it's at. Because one of the things we're going to try to prevent is to try to prevent a lot of extensive systemic absorption of these steroids. Because steroids are very potent drugs. When given systemically, they can cause all kinds of physiologic effects, which we'll look at. And so what we're going to find is, depending on the steroid, you can get more or less systemic absorption. It also applies on where you're putting it at, what concentration you're using, and all of that sort of stuff. So when I'm talking about steroids, I'll talk about their potency. And this is topical steroids I'm talking about. Talk about low, medium, high, super potent steroids. We'll look at all of those in here in just a moment. Typically, these are general rules of thumb here, though. So low potency steroids are good for the face, some intertriginous areas like the axilla, the groin. Good for infants, because again, infants typically have pretty thin skin as compared to older patients here. And these are good for long-term therapy. These are things that patients can sort of fall back to if they have chronic eczema, to kind of maintain them, to prevent maybe a flare from occurring. This is good kind of maintenance therapy. Low potency steroids, and I'll show you what these are in just a moment. Medium potency steroids can be used for sort of across the body, right? So you may not want to use them in the most thin areas, because the thinner the skin, the more absorption you can have there, but they're fine for use for the rest of the body here. And then when you have an exacerbation, you're going to step up the steroid that you're using, either using a higher concentration or just a higher potency steroid in general. And then you'll do that for a few weeks, let the inflammation die down, and then you'll switch back to a lower potency, right? You'll find that there's, again, these peaks and valleys in activity to where you're going to be peaking up as their effects get worse, and then as they get the inflammation under control, you'll step it back down, right? So in general, in terms of adverse effects of topical steroids here, tend to be systemic in nature. So depending on, the more systemic absorption you're going to get, the more side effects you're going to be seeing here. As I mentioned, it's related to the potency they're using, related to duration, how long you're using it for. The longer, the more likely you are to see the systemic effects. The area of the body covered, or how big of an area covering. And then the occlusiveness of the preparation too, right? I guess that's a misspelled word. I guess PowerPoint doesn't recognize this, but again, how occlusive it is. So again, something like an ointment is going to be more occlusive than a cream, which is more occlusive than a lotion. The higher the fat content, the higher the oil content of that product, the more occlusive it's going to be, right? And the more occlusive it is, sticking around for longer, more likely to see systemic absorption, right? So locally, what you can get in terms of the effects here, you can see things like skin atrophy. You can actually worsen acne, because you can prevent the immune system from being able to take care of some of those bacteria, which in some cases helps them to sort of flare up. Rosacea, allergic dermatitis. If they get dermatitis from the steroid, it's oftentimes not due to the steroid itself, it's related to the vehicle. You'll see someone who's like, I have a hydrocortisone allergy, and it's like, well, you can't have a hydrocortisone allergy because you produce cortisol, so you'd be allergic to that. Frequently what they're referring to is usually something else in the product they were taking, like the vehicle itself, a preservative, something like that is what is actually causing the issues there. Systemically, this is what we care about for a lot of patients, is things like adrenal suppression, right? If you're familiar with negative feedback loops, if you are supplying the body with exogenous steroids, it tells the adrenal glands, hey, there's enough steroids here, I don't need to produce anymore, it will shut them down, okay? The degree of that shutdown can be dependent on how much of that absorption they're getting here. That occurs, and you were to say stop giving the steroid altogether, well, the adrenal glands take time to sort of kick back up their production, and so it can lead to things like adrenal insufficiency if you were to stop taking that steroid altogether, okay? So that can be an issue for long-term high-dose use, especially if more potent steroids, you're going to see this adrenal suppression. You may see infections more likely due to the fact that it has a immunosuppressive effect because it's anti-inflammatory. You can see hyperglycemia, especially in patients with diabetes, have degree of insulin resistance or glucose intolerance. I can see that. Worsen glaucoma, worsen cataracts. If you're using it in young children, you may see growth retardation. You can see fluid accumulation in patients with CHF. Blood pressure tends to rise, especially in hypertensive patients. So a lot of effects you can see with this. And again, in another section, I'll go over more into the details of why all of that occurs. But the big thing to know is that you can get away with using the lowest dose steroid possible with the lowest potency. That's going to have to prevent a lot of these systemic effects. But these are things you got to watch out for, especially depending on what the comorbidities of that patient are. If you know they got glaucoma, then using a really high potency, highly occlusive steroid, maybe not great for them because that can worsen their intraocular pressure. You may want to, go back and check that, make sure it's not getting too high, for instance. So sometimes we can dose around these things. It just depends on the situation, right? So here's a good example of a steroid potency chart here. I have some examples in the slides myself, but let me go ahead and show you an example of what this looks like. Switch over. So you can see this potency chart here. You can kind of go through it on your own if you want. You can see how they sort of list their different potencies here. So for instance, they have like super potent steroids here. Those things like clobetasol is one I always think about as being like really super potent. Some forms of betamethasone. Notice here's how they have the different dosage forms. They'll have like whether it comes as a lotion or a cream. Typically the ones that come as an ointment are going to be higher potency because they have more occlusiveness to them. Notice here there's a concentration associated with all these as well. Typically, the higher the concentration, the more potent that they're going to become here. Now, do I want you to memorize this entire list here? How long this list is? It's crazy. Not necessarily. What I want you to take away more so from this is going to be sort of some of the key points, the caveats that I want you to sort of take away from this. And so, going back to the PowerPoint here, in general, what you can see is, that by changing some of these features here, so one, changing the drug entirely can, change the potency for sure. So again, hydrocortisone, this is probably a good one to know as being sort of like the most mild, because you can find this one over the counter, you can find it anywhere. Hydrocortisone is like kind of bread and butter, like, I can use this for, any kind of skin irritation, inflammation over the counter. It's pretty mild, right? All the rest of the stuff is going to be prescription only because, again, they're going to have that risk for carrying systemic side effects. And just topical side effects too as you go up in potency here. But some of the points I want you to take away from this, and again, memorize this entire list would be a fool's errand for our class, because there's just a lot of these. And even if you work in derm, you may not use every single one of these. There's probably going to be a certain stable of ones that you use on a regular basis, and you'll know those drugs super well. But a lot of the rest of them you may never see, you may never use, right? Some of the things I want to point out though are going to be not just the fact that, by increasing the concentration, that can affect the potency. By changing from like a lotion to an ointment, that can increase the potency. Also want you to note too, sometimes the salt form makes a difference too, right? So for instance here, let me show you an example of, like, so if you just have like hydrocortisone by itself, this is just like the base hydrocortisone, it's considered to be sort of like the least potent. But then if you notice here, if I have like hydrocortisone butyrate or hydrocortisone valerate, now it becomes like a lower mid-strength one. And so again, changing the salt form can actually enhance its penetration and can enhance the potency of the steroid too. So rather than knowing every single one of these and which category they fall into, which I would not want you to do because that seems crazy for my class, is to know sort of the conceptual stuff behind it, like what could affect the potency of a particular drug. Vehicle that it comes in, its potency, or in terms of the actual drug itself, the concentration that it comes in, the salt form, all of those things matter. And as you increase potency, what does that mean for the patient? What does that mean in terms of efficacy, in terms of toxicity? Those are the things I want you to kind of look at, okay? Now, there's some other drugs you can use too if steroids maybe were not appropriate for whatever reason. And these are sort of topical immunomodulators, right? So these are going to be topical products used to suppress the immune system. These are things like, or suppress inflammation, I should say. Oftentimes you can find these as well when used systemically as anti-rejection drugs for patients who've had transplant because they are immunosuppressive. But things like tacrolimus and pimecrolimus may be used for patients who have really severe disease or for patients who may be not good candidates for steroids for whatever reason. And we like to hold off on using these if we can, especially because there is some small link to cancer that you'd want to be watchful for there, certain types of cancer. And then patients who already have a weakened immune system, this can worsen that further and can increase their risk for bacterial, fungal infections, and things like that. The biggest thing, though, is that they're going to cause a ton of skin irritation. These are going to be very poorly tolerated by most patients, which is why we use these as backup to steroids. And make sure they use a lot of high SPF sunblocks, like SPF 100. Zinc oxide, totally fine too. It may not be the most comfortable stuff to wear, but it's going to prevent a lot of that skin irritation, that photosensitivity, and sunburns from occurring, because this is very likely to cause that to happen. In terms of other therapies, in some cases for very severe disease, you may find patients will take oral courses of steroids, sort of like a pulse dose kind of deal, where they may do like 5 days worth of oral steroids, and then once that is tamping down that flare up, then they can go back on their topical products there. So you may see that occasionally with drugs like prednisone, dexamethasone, or methylprednisolone, depending on the case there. Sometimes you may even have patients who have like a taper built into, where they may kind of slowly decrease the oral dose until their topical product can sort of kick back in and start to work again. So it's something you may see there. In terms of other topical antibiotics, I'll just cover this real briefly just so we can keep on track here. So this is going to be like topical antibiotics used for like a lot of like first aid stuff, like skin, topical mild skin infections. Most of these are over the counter. I'm going to find here. First one's bacitracin. This one's working by preventing cell wall synthesis. Bacitracin is really toxic if used systemically, which is why we didn't cover it in the last PowerPoint, but very good when used topically because it doesn't have very good absorption. So really handy. Has a ton of different things it'll cover, including like anaerobic stuff, tetanus. So if you have like someone scrapes their arm on the ground or something, or they fell and had a big scrape on the ground, like this can cover all that stuff that would normally be growing there and on the skin. So typically either used by itself or in combination with things like neomycin and polymyxin B. So if you ever hear like double antibiotic ointment or triple antibiotic ointment, it's usually bacitracin in combination with either neomycin and polymyxin B. So it just depends. And again, maybe some allergic dermatitis for some people who are really sensitive, but otherwise no real systemic effects, no other big issues with bacitracin. These are very safe drugs here. Mupirocin is occasionally used, called Bactroban. This is actually going to be used a lot for MRSA specifically, and typically what we're going to use this for is on the nares for patients who are maybe colonized with Staph aureus. This is really important for like hospital infection control for patients coming into the hospital. If you ever hear like a staph or MRSA nasal swab, they'll do that, and if they are positive, then they'll give them a dose or they'll give them a course of Bactroban to try to prevent that spread of MRSA to other people potentially. So very handy there. Again, not absorbed, but may see some mucous membrane irritation as you are applying it to the nares. A lot of it has to do with the vehicle that is put in. Next up, polymyxin B. This is another one that you don't really see used systemically because it causes such nasty side effects from a systemic standpoint, but topically it's really great because it, again, has really good coverage against a lot of gram-negative drugs, negative bugs. It will disrupt their cell membrane pretty significantly, so it works on Pseudomonas and all kinds of other gram-negatives. And again, not a lot of systemic reactions. The one thing you'd want to be careful though is if you're using on like large open wounds or areas of like denuded skin, that can increase the risk for absorption and can increase risk for things like neurotoxicity. You may see some changes in mental status. You can even see kidney injury occur here, but this is rare. It would only be for patients who have like a really significant injury and you're applying this to a large area of unprotected skin, right? And then we have our aminoglycosides here. This typically includes like neomycin or gentamicin, which you've seen previously. Again, good gram-negative activity. This is probably the most likely one you're going to find that will cause actual skin irritation or skin sensitization. If patients are going to have an allergic reaction to one of these topical antibiotics, it's probably going to be neomycin. For whatever reason, it tends to just be the most irritating from an immune standpoint. Again, unlikely to have systemic effects unless you're applying it to really large areas or you're applying it to areas of broken skin, things like that. So those are common topical stuff you're going to find in a lot of like, first aid things, topical anti-infective treatments. So that's it for this section. Sorry, I went over a few minutes, but that's okay. We got caught up. Let's see if there's any questions over here. I don't see anything on the sticky board. Do you guys have any questions in the chat that I can answer for you before I let you go? If not, you're free to go and take that quiz. Let me know if you have any questions based off of that. Again, you can take as many times as you want just to get you some extra practice prior to an exam. And other than that, you guys have a great day, and I'll see you next week. You guys are my least talkative bunch, but I'm going to chalk it up to these 8 o'clock classes. It's just not really tenable for anyone. But if you're going to work in medicine, disease never sleeps, so you got to get up early. Everyone's still sticking around, but no one's asking questions. So I will release you myself. I'll end the stream, and I will see you next time. Have a great day.